Step to the Future 1 كانت البداية، وكان أول مؤتمر للجمعية المصرية لزراعة الأسنان، واتعمل في اسكندرية سنة 2018. كان مؤتمر جميل جدا، ونجاح المؤتمر ده خلانا نفكر إننا نعمل تاني مؤتمر 2019 Step to the Future 2 اللي كان برضو نجاح منقطع النظير. وكملنا بعد كده بستيب تو ذا فيوتشر 3 اللي اتعمل سنة 2020، وكان الحمد لله نسخة أنجح من النسختين اللي قبله كمان، وحضور كان كبير جدا. لكن بسبب الكورونا اضطرينا ان احنا نتوقف لفترة، ورجعنا لكم تاني بستيب تو ذا فيوتشر 4 سنة 2024. لكن النسخة دي كانت اونلاين، وكانت في شهر رمضان الكريم، وكان معانا سبيكرز كتير جدا. نجحت قوي النسخة، ودخلنا في 2025 ستيب تو ذا فيوتشر 5 وبعدد اكبر من الدكاترة، وعدد اكبر من السبيكرز، وعدد كمان كبير من السبونسرز والشركات اللي بتجيب لنا هدايا. واخيرا السنه دي ستيب تو ذا فيوتشر 6 سنه 2026 في رمضان ده، منتظرينكم تتفرجوا على المحاضرات. كورس الزراعه بتاع الجمعيه المصريه لزراعه الاسنان بدا من سنه 2006، يعني بقاله دلوقتي 20 سنه، يعني يعتبر اقدم كورس امبلانت قائم لغايه النهارده في مصر. الكورس ده فيه محاضرات، وفيه نظري، وفيه ورك شوبس وعملي، يخلوك قادر ان انت تشتغل معظم حالات الزراعه اللي بتيجي في العياده عندك. بتدرس من اول انترودكشن وكل حاجه، وتريتمنت بلاننج، والسيرجيكال بروتوكول، وبيشنت سيلكشن، والسوفت تيشو مانجمنت، هارت تيشو اوجمنتيشن، والبروسيسز والكومبليكيشنز والفيليرز. وكمان بتشتغل بايدك على بيشنت، يعني انت بتتدرب على كل حاجه، بلس مجموعه من الورك شوبس. مش هتطلع من الكورس ده الا وانت ان شاء الله عارف تشتغل كويس. آلاف الدكاترة أخدوا الكورس ده معانا، وإن شاء الله ربنا يقدرنا وآلاف تانيين هياخدوا الكورس. يلا تعالى جوين الآلاف اللي هياخدوا الكورس معانا.
مساء الخير وأهلا وسهلا بكم في النسخة السادسة من المؤتمر السنوي الرمضاني Step to the Future للجمعية المصرية لزراعة الأسنان. معاكم دكتور يوسف حمدي. في البداية بنحب نشكر سبونسر محاضرة النهاردة شركة أكسس دينتال على دعمهم الدائم للمحتوى العلمي والتعليمي المستمر. وكمان حابين نفكركم إن معانا النهاردة 20 جايزة مميزة. كل اللي عليكم تعملوا منشن ل5 من أصحابكم في الكومنتس، وكل ما تعمل منشن أكتر كل ما تكسب أكتر. ويشرفنا النهاردة وجود دكتور نيفين محمد، من أهم وأبرز الأطباء في مجال الإمبلانتس، واللي أكيد هنستفيد جدا من خبرتها ومحاضرتها القيمة النهاردة. دكتور نيفين اتفضل.
اهلا، ازيكم؟ كل سنه وانتم طيبين. هنبتدي ان شاء الله لكتشر النهارده Augmentation versus Minimal Intervention. حالا كده تمام، واضحه السكرين؟ دكتور يوسف معايا؟
واضحة تمام يا دكتور.
دكتور يوسف واضحه تمام. طيب today we will talk about augmentation versus minimal intervention, choosing the right implant strategy. امتى بنعمل augmentation وامتى بنختار ان احنا to go minimal invasive؟ أنا دكتور نيفين الجمال، أعرفكم بنفسي Assistant Lecturer in Future University in Periodontology Department, Master's Degree عين شمس University، و PhD Researcher في كايرو University، و ITI Member. Okay. Implant dentistry is driven by biology, function, aesthetics, and long-term stability. So in all the cases, whether anterior or posterior cases, we have to deliver biology, function, and aesthetics to the patients. So how we will do this? By choosing implant timing based on the socket anatomy and avoiding all the risks. Decide when the hard tissue augmentation is mandatory or optional. Decide when soft tissue augmentation improves maintenance and stability, and plan the implant position restoratively for the emergence profile and the screw axis. So we will have to apply this framework to all the cases. Diagnosis first, to decide whether we're going to do a hard or soft tissue augmentation, the timing of the implant placement, whether it's an immediate, early, or delayed implant placement according to the case, hard tissue augmentation, are we going to do a ridge preservation, guided bone regeneration, or going to do a staged augmentation, to assess the soft tissue phenotype and keratinized mucosa, and to do the prosthetic plan, the emergence profile, and the access of the screw channel. So from the beginning of the case, we have to apply this framework to all the cases that we face in our daily practice. Diagnosis for the hard and soft tissue, timing of the implant placement, decide the hard tissue augmentation technique, whether it's going to be staged or simultaneous placement, the soft tissue phenotype and keratinization, to decide whether we're going to do a soft tissue augmentation either before the implant placement, during the implant placement, or after the healing phase, and the prosthetic planning. So before we start any implant case, we have to do this framework and decide all the steps from the diagnosis till the prosthetic planning. So options available for the implant placement after tooth extraction: either at tooth extraction, we do an immediate implant placement, or we do an alveolar ridge preservation, and it has specific indications. مش في كل الحالات طبعا بنعمل alveolar ridge preservation. It has a very few indications, and we will say it inshallah next في الcases. After tooth extraction, either early soft tissue healing after 4 to 8 weeks, partial bone healing after 2 to 3 months, and full bone healing after 4 months. So what is the advantages of the delayed implant versus the immediate implant? Delayed implant, we have a healed bone, a healed soft tissue, a better primary stability, and a favored implant direction. But we have a disadvantage that we have sometimes a crystal bone resorption, and to achieve zero bone loss, we have to apply all the rules of the soft tissue height and the soft tissue thickness and the implant positioning and the buccal bone plate thickness that we will see later. So this is the disadvantage of the delayed implant placement. The immediate implant placement, of course, we save time for the patient, we have patient satisfaction, we have comparable results with the delayed implant. Of course, all the data now and all the evidence that we're having a comparable results of the immediate implant placement and the delayed implant placement. But sometimes we cannot do an immediate implant placement if we're having an acute infection, if we're having if we will have a bad restorative position. That's why I said that we have to decide all the framework of the case, starting from the diagnosis till the prosthetic placement, before even starting the surgical procedure. So we have a better planning. So in the case selection and the pre-treatment evaluation, which is, as I said in the beginning of the lecture, is very, very important. So we have a successful results and a long stability of the implant. We have to consider all the patient factors: the smile line, soft tissue biotype, the bone availability, and of course the radiographic and the clinical assessment, the CBCT, and the occlusion of the patient. So one of the very important treatment planning consideration is the implant positioning, the 3D implant positioning. If we place the implant in a correct 3D implant position, we will save ourselves from a very big future hassle of the wrong positioning and the need of the soft tissue augmentation, and even to remove the implant and place another one. So the 3D implant position in the anteriors, buccolingually, we have to have at least 2 millimeters of the buccal bone. Mesiodistally, 1.5 millimeter between the implant and the roots, and 3 millimeter between implants. Epicocoronally, 3 to 4 millimeter apical to the adjacent CEJ or the gingival margin. So we have to put a reference for ourselves. posteriorly, it's the same, but the posterior is little bit forgiving than the anterior because we don't have an emphatic problem as in the anterior zone. So we can have only 1 millimeter of the buccal bone. And mesiodistally, it's the same as the anteriors. We have to have a 3 millimeters between two implants and at least 1.5 to 2 millimeter between the root of the teeth. Epicocoronally, we can have as just 2 millimeter apical to the adjacent CEJ of the tooth. So it's more forgiving than the anterior zone. Okay, so one of the most important planning considerations in the anterior zone is the rule of 5 according to Ternau, that we have to have at least distance of 5 millimeter between the contact point and the alveolar crest to allow good aesthetics and tissue fill in the papillary region. Okay, so what will happen if we didn't have this space? If we have more than 5 millimeter between the crest of bone and the contact point. If we're having more than 5 millimeter, we will have a less percent, 50% less chance of papilla fill. So that's why we have to know all the case from the beginning. We have to do all the proper planning and know what is the expectation of the case. So even to have the patient's expectations. Okay, this case, if we're talking about the minimal investment, alveolar ridge preservation followed by implant placement and soft tissue augmentation. In this case, we didn't have enough bone apically to do an immediate implant placement, so we choose to do an alveolar ridge preservation to preserve all the, and also we had a very thin buccal plate of bone. Here, after we placed the xenograft, almost 50% of the socket, and then we placed the collagen sponge and we did cross horizontal mattress suture. Okay, this technique, I do it in my thesis. It's called layering technique, biologically oriented alveolar ridge preservation. We do layering. We place first collagen sponge, and then we place the xenograft, and then we place the collagen sponge on the top. And the hypothesis of this technique that we only need a 2 to 3 millimeter of bone in the coronal area only. We don't need in the apical part, as in the apical part, we only need the blood clot, so the cells come and proliferate, and we have the osteoblast for the bone, for the native bone formation. Okay. This is a re-evaluation after 4 months of extraction and alveolar ridge preservation, as you can see. And you know that for complete remodeling of the xenograft, we have to wait at least 6 months, but we can also, it's from 4 to 6 months, but if we want to see a complete native bone, we have to wait for 6 months for the xenograft. Okay, this is another case for the alveolar ridge preservation and why it improved predictability. So we said from the beginning that the alveolar ridge preservation is indicated in not all of the cases, but only it has few indications, and it's one of the minimal invasive techniques as it saves us from doing a huge guided bone regeneration techniques in some of the cases. So I consider it one of the minimal invasive. Its only disadvantage that it increased the time of the patient and the time of the case, as we have to wait 4 to 6 months to place the implant. So it limits the ridge collapse. It creates conditions ideal for the 3D implant placement in some of the cases. It reduced the need for larger GPR later when possible. So in this case, we had, this is a molar, but a small molar. This is upper right 6. After I extracted, there was a buccal bone loss, and even it was evident in the CBCT. That's why we didn't do the immediate implant placement. Also, the interseptal bone was a little bit deep, so the implant restoratively later on won't be in the best option. So we extracted, I placed the xenograft, and I placed a collagen membrane, and then I closed with a membrane. And here we have, this is the implant placement after 5 months, and this is the after the final crown delivery. Okay, here is the stage of the implant placement after 4 months. We have 2 implants, the 5 and the 6. Ensuring parallelism between both implants is very important. This is a J-dental implant. And this is after suturing. This is after the crown delivery. But we had a problem here, as we can see at the 6. We don't have keratinized tissue. It's all a movable mucosa. So I even suggested for the patient before even the restorative part, but the patient wanted to have the crown delivered. So after that, I told her about this problem and that she will have a problem in teeth brushing and in long-term maintenance. So the patient was convinced and went for the soft tissue free gingival graft. And this is after 4 weeks of the free gingival graft. We have here, we can see the increased keratinized tissue and the mucosal thickness. And then these are healing abutments. And by the way, the patient had a problem in the bite, and she has a limited vertical dimension. So that's why posteriorly we chose a very small healing abutment. So the role of the keratinized mucosa on the risk of peri-implant disease and soft tissue dehiscence, according to the evidence, this paper was published in 2024 for Rakuzu, and we have a conclusion that the tissue-level implants placed in the posterior mandible without keratinized tissue showed greater marginal bone loss, bleeding and propping, soft tissue recession, and peri-implant disease compared to implants with keratinized tissue at 20 years follow-up. That's why in the previous case we insisted on the patient to have the keratinized tissue augmentation with the free gingival graft. Okay, this is another case that I consider as a minimal invasive, also a minimal invasive option to do a closed sinus lifting with denser drills, compared of course to the open sinus lifting or the other techniques. Here we were having a length of 8, or a height of 8 millimeter. We didn't have a problem in the width. So this is the protocol of the osteodensification with the denser drills when we're having marginal ridge height more than 6 millimeter. Okay, we measure the height to the sinus floor according to the CBCT that we have. We place our pilot drill 1 millimeter below the sinus floor, and we take a periapical X-ray to make sure that we didn't perforate the sinus. And then we go sequentially with the denser bears, starting from the 2 millimeter, the smallest one, okay? And up to 3 millimeter, we go sequentially until the final drill, okay? And we do it in a reverse mode, counterclockwise mode, okay? And we're having the speed from 800 to 1200 RPM, okay? And here, as we see, the sinus, okay? So we make sure that we didn't perforate the sinus, and this is after the implant placement. We only had here 2 millimeters of sinus lifting. Okay, another case of crystal sinus lifting, closed approach, protocol 3. As we see in this case, of course, we have here a huge sinusitis in this case, and even we prescribe the patient's nasal decongestants for 3 months before the surgery. Anyway, this was just for planning. We have, in this case, only residual bone height around 3 millimeter at the 6. So we did a closed sinus lifting with denser burrs and bone graft. Okay. So also I consider this a minimal invasive approach, and instead of, before we used to do this case as an open sinus lifting, and of course we know the open sinus lifting procedure for the patient and the complications that we might have from the open sinus. Here we have, this is the baseline, this is after the flap reflection, this is the sequential drilling. At the beginning we said we go with the pilot drill just 1 millimeter below the sinus floor, and then we go sequentially with the drills. This is also the first drill of the densa, and then we go sequentially. Here, this is the last drill. I added the bone and I took the periapical x-rays. This is to ensure parallelisms. And here we have the bone cloud around the implant to ensure that we didn't have any perforation and we have our procedure done correctly. So what is the most common complications of the closed sinus? We said it's a minimal invasive, and if we're having the option to do it than the open sinus, of course, it's going to be a better option for the patient and even for the dentist, but he has to have experience with it. So the most common complications is the membrane perforation. It's a blind technique. We don't see the PPV, okay, with the osteotome technique if we didn't do it with the densa drills. We have also, of course, in the literature, we have a lot of techniques for the closed sinus. It's not only the densa burrs, but for me, it's a magical tool and it's a very minimal invasive technique. We have the osteotome technique, but with the malleting for the patient, we can have some complications and discomfort for the patient. And of course, if we're having sinus pathology already, even before we start, it's going to be more aggravated and increase after the treatment. So we have to deal with the sinus pathology first before the procedure. Okay. So to optimize the aesthetics for the implant in the aesthetic zone, as we said, in the planning phase, we have to have at least 1.5 to 2 millimeter placing the implant palatal to the incisal margin of the central maxillary and to have a 2 millimeter of buccal bone. This is another case of immediate implant in the aesthetic zone. Here, central incisor, we extracted atraumatically, we placed the implant, and of course we're having the dilemma of the jumping gap here, to graft or not to graft. According to the evidence, some evidence showed that jumping gap grafting does not reduce the horizontal bone resorption regardless of the buccal bone thickness. Another evidence showed that it achieved a better aesthetic outcome. So we're having always a debate whether to graft or not to graft the jumping gap. Okay, and also according to a recent evidence that it will be according to the thickness of the buccal bone. If we're having a 1 millimeter or less than 1 millimeter thickness of the buccal bone, it's better to augment the jumping gap with allograft, of course, better. And the second option might be a good xenograft. Okay, so this was the PMMA. At the time of the implant placement, we did an immediate loading, and this is the final restoration of the central incisor. This is the final after patient smiling. Of course, we know that the central incisor cases are the most challenging. So remember that we have the case evaluation matrix, the hard tissue, more than 1 to 2 millimeter of buccal bone or not. We're going to augment the defect type, the space maintenance needed, the soft tissue, keratinized mucosal width, the phenotype, the vestibular depth, and patient hygiene and aesthetics. Prosthetics, the screw axis, the emergence profile, the crown height space, and the cleansibility. and to evaluate the risk factors of the medical condition of the patient, smoking, the periodontal history, the parafunction, and the maintenance of the patient. Okay, so we're having another case, implant in the hepatic zone, but this time we had to go with a GPR and an augmentation technique. We had a less than a 1 millimeter or less than labial plate of bone, and of course we're in the hepatic zone, and as we see we're having also some concavity in the bone apically, so we decided to do a GPR or a contour augmentation. In this case we have the thickness of the bone, as we see, less than 1 millimeter, so it's an indicated for a contour augmentation, but we're having the labial plate of bone intact. So the debate of, do we need the buccal bone or not? What do we do? Shall we do a hard tissue augmentation, bone augmentation, or we do a soft tissue augmentation, or we do both? We will answer this also in the next cases, but this is a very important question to keep in mind. Okay, so we did here bone augmentation with xenograft, and then we placed the collagen membrane, and we did periosseal sutures. We didn't, yani for my point of view, I didn't need to put tacks, as we're already having the bone, the labial plate of bone is there and intact. Okay, so this is an evidence according to Stefan Urban, the vertical bone grafting and the periosseal vertical matrix sutures for the fixation of the resorbable membranes and stabilization of the particulate grafts in the horizontal defects, as he uses resorbable sutures. And of course, it's a very successful technique according to Stefan Urban and according to the evidence. And this is after 6 months of the implant, 5 months of the implant placement. But here we have a little bit challenge that the screw axis, we know from the beginning that it's going to be hard to place it in a screw axis crown, screw retained crown. So either we do it a cement retained or with a customized zirconia abutment. So what are the prosthetic options if the screw axis is slightly off? Okay, so the previous case, because we decided to do it simultaneously, the augmentation with the implant placement. Another option we had is to do it a staged approach. Okay, so we can place the implants in a more 3D prosthetic position. Okay, so if the screw axis is slightly off, we can use angled screw channel, angled abutment. We can use customized zirconia abutment. And of course, when compensating later, it can increase the complication risk. So we have to position the implant in a correct 3D implant position to simplify the prosthetics options later. So in the previous case, we could have an alternative plan of a staged augmentation. Okay, and this is how the crown at the end, we're having a 15 degree, 13 degree, and a 45 placement of the implant parallel to the cingulum. We're going to have a very big angle from the axis of the implant and the crown margin. So that's why we have to plan everything before the start of the surgery. And of course, we know the EBC concept, the aesthetic biologic concept, according to Gomez Meda in 2021. We're having the 3-zone, the crystal zone immediately at the implant, and the bounded zone and the aesthetic zone. And of course, the C and B zone is straight or slightly concave, and then the E zone, the aesthetic zone, is slightly convex, so we can have a good emergence profile and a zero bone loss concept, as in this case we have a 5-year follow-up and we have 0 bone loss in this case. So in the hard tissue augmentation, if we're going to do a hard tissue augmentation, if we're having a buccolingual bone width more than 3.5 millimeter and we have a good primary stability, we can go for a simultaneous approach. If we don't have a good primary stability, we have to do it a staged approach. And if less than 3.5 millimeter, we can do onlay graft, and according, of course, to the tissue thickness. And if 4 to 5 millimeter, we can do ridge splitting or expansion, especially in the premolar area of the maxilla. So what will you choose? Staged approach, simultaneous approach, ridge expansion, or which technique you will choose to do in the hard tissue augmentation procedure? We have to know the guided bone regeneration concept, the pass roll, the primary tension flea closure. To have a successful guided bone regeneration, we have to follow the pass rule, which is primary tension free closure, angiogenesis, stability, adequate fixation, and space maintenance. So again, according to Stefan Urban, horizontal ridge augmentation with collagen membrane and a combination of the particulated autogenous bone and the anorganic bovine bone mineral. We're having this case sausage technique with simultaneous implant placement. As we can see, we have 4.2, so we can do it a simultaneous approach. Here we have this defect, as this case already had a staged, had here an alveolar ridge preservation. So we have this defect crystally, dehiscence defect. So we placed the first gel of the implant palatally, as we said, to have a future screw channel, screw retained implant, and the screw channel to be palatally at the cingulum area. So after the implant placement, we did the sequential drilling, and it was only, I think, 2 drills we used. And then we placed the implant, and then we fixed the pericardium collagen membrane. This is, we fixed it palatally with 2 tacks, so we can pack the bone crystally. Okay, so according to Urban, to push the bone upward to the crest, we have to fix palatally first. Sometimes I fix from the buccal, but 99% we do it from the palatal side to have the bone pushed crystally. And this is after mixing the xenograft with the autogenous bone. And by the way, in this case, I used something called Theravex. It's a new innovation that it claims that it brings the stem cells so we can have a vital bone later on and increase the healing and fasting the healing of the bone. It's called Theravex, and we mix it with the bone instead of the saline. This is, and even it improves the handling of the bone. It's like a sticky bone in handling, so it even improves the handling of the bone. And they have evidence on this 50% autogenous, and this is a 50% xenograft. Here we placed the tacks from the buccal side to fix the membrane, and according to the Urban, we have to have a rock solid sensation of bone beneath the membrane to have a successful augmentation and sausage technique. And here we can see, so we achieve a primary tension free closure. We have to do a very good release. Okay, according to the case here, I did 2 preosseal releasing incisions a superficial and a deep one. And this is after. Here we have a double flap closure technique for primary intention healing with horizontal mattress sutures and interrupted sutures on top. And this is after. Okay. So according to the evidence, if we're having less than 3.5 millimeter, we're going to go for a staged approach. If we're having more than 3.5 millimeter, we're going to go for the simultaneous approach. So this is the last case with us. This is a staged sausage technique and followed by implant placement at tooth number 11 and 21. كان عندنا missing upper central, two centrals, right and left, and the lateral. And by the way, this patient had an orthodontic treatment, and she's a young age patient, she's 23. She reported that she had a very big cystic lesion, and this defect was from the time of the extraction, and even she used to use a denture before this procedure. Okay, this is after the flap reflection. Here we did the decortication of bone to increase the vascularization. Even in the maxilla, we don't need it this much. This is the autogenous bone, and this is the xenograft, and this after we mixed 50-50 autogenous and bone graft, xenograft. This bone is from Ubigen and also the pericardium membrane, and we fix it with tacks and also periosseal sutures. And here we have the double layer closure also to have a primary tension free horizontal mattress. And this is at the follow up at 3 weeks. As we can see, we have a stable closure and we have a stable wound. We don't have any wound dehiscence because we had a very good primary tension free closure. And also, so we can preserve the bone and we don't have any bone loss or any infections. So, but even it was a resorbable membrane, so we don't have this big risk as if we're going to placing a non-resorbable PTFE membranes. And this is after, of course, we had a very big augmentation and we had a good bone compared to the before. Okay, and of course ignore the measurements, it's not correct, but we can see the difference between the before and the after. So this is after, and this is the healing of the soft tissue. Of course, I suggested for the patient to do even further soft tissue augmentation, but she was okay, and even she had a low smile line, so we didn't need this much of soft tissue augmentations, but for the long term, and we had a good thickness and keratinization. Okay, so in the GPR procedures, we have to prevent the complications, and the most common threat is the membrane exposure, especially in the non-resorbable membranes, the PTFE. And we prevent this with the tension-free closure and adequate keratinized tissue. And of course, this to be discussed in the soft tissue augmentation and soft tissue around implant, when to do the soft tissue augmentation, whether before the implant placement or the augmentation technique, or during or after, according to the case. And of course, the early management, the good oral hygiene, and the chlorhexidine rinse and the close monitoring prevents a lot of complications from happening. And if we're having an exposed non-resorbable membrane, when to remove it, and to consider the soft tissue augmentation first if we're having the problem in the soft tissue. Thank you so much. And for any inquiries or questions, this is my account. Thank you.
شكرا جدا يا دكتور، جزيل الشكر على المحاضرة الرائعة عن الإمبلانت. كانت محاضرة مميزة وغنية بالمعلومات، واستفدنا جدا من خبرة حضرتك، وشكرا جدا ليكي.
ميرسي قوي.
بس أنا كنت عايز بس أقول عن الجيفتس الموجودة النهاردة. عندنا 3 جيفتس من دنتال شوب، سانيتايزرز. سامع؟ ألو؟
ايوه.
أيوة تمام. عندنا 3 جيفتس من الدنتال شوب، عبارة عن السانيتايزرز، وعندنا من التوث ميت 1 سيل ميت سيلر، يعني يعتبر توتال 4 جيفتس. وطبعا احنا عارفين ان احنا هنختار الكومنتس عن طريق الكومنت بيكرز. وبس كده، وشكرا لحضرتك، وشكرا على وقتك ومجهودك، ونورتي المؤتمر يا دكتور.
ميرسي قوي، شكرا.
كورس الزراعة بتاع الجمعية المصرية لزراعة الأسنان بدأ من سنة 2006، يعني بقاله دلوقتي 20 سنة، يعني يعتبر أقدم كورس إمبلانت قائم لغاية النهاردة في مصر. الكورس ده فيه محاضرات وفيه نظري وفيه ورك شوبس وعملي يخلوك قادر ان انت تشتغل معظم حالات الزراعة اللي بتيجي في العيادة عندك. بتدرس من اول انترودكشن وكل حاجة، وتريتمنت بلاننج والسيرجيكال بروتوكول وبيشنت سيلكشن والسوفت تيشو مانجمنت، هارت تيشو اوجمنتيشن، والبروسيزز والكومبليكيشنز والفيليرز، وكمان بتشتغل بايدك على بيشنت. يعني انت بتتدرب على كل حاجة بلس مجموعة من الورك شوبس. مش هتطلع من الكورس ده الا وانت ان شاء الله عارف تشتغل كويس. آلاف الدكاترة اخدوا الكورس ده معانا، وان شاء الله ربنا يقدرنا وآلاف تانيين هياخدوا الكورس. يلا تعالى جوين الآلاف اللي هياخدوا الكورس معانا.